Good morning and welcome to the first spring meeting of the Payment Models Work Group. My name is Kate Grimm. I'm a rate analyst here at the HSCRC.
And I'm Dion Joyce, a rate analyst here at the HSCRC. We would like to go around and have everyone introduce themselves since this is our first meeting, so everyone can get acquainted with one another.
Good morning, everybody. I'm David Johnson with Simpson Consulting.
And I'm Michelle Mann with Frederick Regional Health System.
Barbara Brocato, Brocato & Associates.
Mike Robbins with the Maryland Hospital Association.
Kim Repack with Western Maryland Health System.
Kristen Pulio with Adventist Healthcare.
Ed Baranek, Johns Hopkins Health System.
Hank Franey, University of Maryland Medical System.
Paul Parker, Maryland Healthcare Commission.
Trisha Roddy, Medicaid Program.
Bob Murray, representing Care First.
John Hamper, Care First.
Stu Gutterman, Academy Health.
Shorty Getovich, HSCRC.
Donna Kinzer, HSCRC.
And Jerry Schmidt, HSCRC.
Is there anyone on the phone?
Yes, there's it's Ian Mack and also Mary Jo Bray Ford has joined.
Okay. Today we're going to start with a model progression update and lead into an update factor discussion, followed by Shulay discussing the performance-based programs update. Donna, do you have anything else to add?
No, well, we'll jump right in and kind of set just a little bit of background in terms of where we're headed with the all-payer model. At a very high level, I think the focus in the system in the first year was getting hospitals on the global budgets, and then the second year was focused on making those global budgets work and getting policies in place around the global budgets, as well as planning for interventions to focus on complex and chronic care interventions. And so a lot of this past year, starting back in January, we started with a care coordination work group that made recommendations, and then hospitals and regional partnerships have developed plans. And this year, 2016, is hopefully a year for progressive implementation of those plans with a focus on complex and rising risk patients, including those that are in long-term care and post-acute settings. We have been, in addition to that planning process, the HSCRC, Department of Health and Mental Hygiene, and MHA and others have been focused on working with CMS to get some approvals and data to support activities, including some approvals to hopefully focus on the ability to do gain sharing, which has been renamed other things in federal lingo now, internal cost sharing, and we've been working on several programs for that, and also to share care coordination resources across the delivery system to implement these complex and chronic care intervention programs. Also, we have been focused on getting system-wide data to be able to help in this process, as well as to monitor the impact on the total cost of care when interventions are implemented, but also to help us be able to select the patients who can benefit most from complex and chronic care interventions. The state has launched a planning process also focused on the future, and we have had several initial meetings with an advisory council. Also, a dual eligible work group has been formed by the Department of Health and Mental Hygiene, and we are working on looking at options for the dually eligible population, as well as the progression and fitting that into the progression of all-payer model. Areas that we're particularly focused on in addition are post-acute and acute care optimization, as the model is progressing, and we'll talk about in a few minutes. We do see some cost increases in the post-acute side, and making sure that we that those cost increases don't undermine savings for Medicare are critical to the success of the model, but also making sure that they're implemented in an optimal way is important to the success of the model. As we move forward, in terms of implementation, we also need to take into account what is going on in the physician side of the world. The MACRA law, which was a law that was passed that included provisions to change the SGR system. In effect, the SGR system was a system that ratcheted down physician rates when volumes went up beyond the federal projections. Is the brief description of how it worked. That law was repealed, but in its place was a law under MACRA that requires physicians to come under value-based payment systems and potentially alternative payment models. Starting in 2019, physicians who are under qualified alternative payment models may receive a 5% increase in their fees, while other physicians are held under a system that may increase or decrease their fee schedules. So there's a very significant amount of attention in the design that we need to pay to our physician colleagues as we move forward. In the slide deck that we sent out to you, some of the high-level comments coming from the advisory council was that we need to focus on concrete initiatives that we can accomplish in the time frame of the model. Said avoid a scattershot and stay focused. The advice was to focus on the high needs and complex patients and rising risk patients with multiple conditions, focusing first on Medicare fee-for-service, since those are the patients that have the fewest supports in the system, and I think sitting in the meeting, the data, we need data was something that was repeated constantly. The need to engage physicians and the need for alignment tools, as well as the need to focus on post-acute and long-term care as vitally important as we move the model forward. And also, I think the advice, the preliminary advice was to test several accountability approaches, building on existing models. Don't reinvent the wheel. But that is actually a topic that will be of ongoing discussion in the Advisory Council. And in terms of focusing on today's topics and ongoing discussions that started last year in our update process when we put money in rates to help focus on developing interventions for complex and high needs patients. Some of the thinking that has been developed is that we have 25 to 40,000 complex patients based on different ways of classifying patients in the system, and at least 100,000 patients that we would classify as quote unquote rising risk who need interventions, who need chronic care management interventions in the Medicare system. And that amount, depending on whose models you're using, might be as high as 200,000 patients. So, so a continuing conversation of how do we approach scaling up the services for these high needs patients, and how do we make sure that the services are being provided in a patient-centered and effective manner. Just briefly, I mentioned that we were focused on changing the slide, on getting several amendments to our all-payer model to support alignment activities, and specifically, there are two general types of programs that we're focused on in the alignment amendment. And one is an internal savings program for providers practicing at hospitals, which is designed to reward improvements in care delivery that create efficiency and cost savings delivered for acute care events. And you all probably would also know that as the MHA gain sharing model, for those of you who have been participating in the process of discussing that in the past. And they've been working on that now for, I think, several years. The second is a pay for outcomes program for community-based providers that is focused on providing incentives to focus on high needs patients, the complex and rising needs patients, and when the interventions result in reductions in avoidable hospitalizations, particularly PQIs and readmissions and other PAUs, potentially avoidable utilization as we measure it, that some savings according to a formula could be shared back with the hospital or the community providers. In particular, the focus would be on providers who are performing chronic care management services under the Medicare program, and aligning the selection of those patients around those who have complex conditions and the highest needs, to make sure that we're focusing the efforts on the patients who can benefit most. So there are additional information about these programs that were included in the slide deck. Today may not be the day to go through them in full detail, and we will be planning activities with with the Hospital Association and MedChi and other physician organizations to discuss these programs in more detail. But in short, they're focused on helping us move the model forward to greater alignment with non-hospital providers in terms of focusing on improving, reducing avoidable utilization and improving the quality and effectiveness of the delivery system. In terms of framing the discussion today, we also wanted to quickly run through some of the performance indicators for calendar year 2015 and the implications of those performance indicators for the update model. These are statistics that many of you will have been familiar with from our commission meetings. They show the all-payer revenue growth over the periods, and we have the fiscal year 2016, and we also have the calendar year 2015 figures that are presented on a monthly basis. And the first set of graphics that we present are an increase in gross revenue, or in all-payer revenue, and you can see that through December, the all-payer revenue growth was just under 3% on a calendar year basis. The in-state portion, which is what we pay the most attention to because it is what we're monitoring for our per capita revenue growth requirements, the in-state revenue growth for the calendar year was about 2.85%. We also monitor the Medicare fee-for-service revenue growth in a similar way.
You're showing a huge increase in the out-of-state business from, in the slide before that, from calendar year 15 to fiscal year 16. Do you know what's driving that? It's for calendar year 15, it was 0.47, and then for the first 6 months of fiscal 16, so it'd be the last 6 months of the calendar year, it's 296. Have we done any analytics around that and just see what's driving that out-of-state business and where it's going?
We do regular analytics on it, but I don't recall off of the top of my head what the 6-month figure is. There have been some rate adjustments that have affected that as well. So, but I don't recall right off of the top of my head. I do recall that in the July through December period of I'm trying to get my date straight, so I'm always trying to get my
through December. If there was
the
a large
July through
increase
December, the July through December of fiscal year 15.
Calendar 15.
No, fiscal year 15. So this is an increase over fiscal year 15.
Yeah, it'd be the last 6 months of calendar year 15.
Right. So in that time frame, Johns Hopkins was undercharged on its out-of-state business, and so this year it's right-charged on its out-of-state business. And so that particular undercharge to right-charge could create a deviation in the numbers that really isn't an indicator of volumes. We track the ECMAD volumes for out-of-state, and we track the the charging, and so that is a factor that occurred in that time frame that could account for difference, because Hopkins has a very large out-of-state business, and a charging variation could affect it. It was having problems calibrating its
rate-related than volume.
That's my that's on the surface. That's my guess of what's going on there, and I've researched it in the past, but I fail to remember right at this moment in time.
Okay.
But that's my best guesstimate based on the conditions that I know that we were having some balancing problems between the GBR and non-GBR rates for in-state and out-of-state.
Thank you.
The in terms of the Medicare fee-for-service growth, we have the gross revenue growth for Medicare fee-for-service, and we'll look at the per capita growth in a minute, but in general, we expect the gross fee-for-service revenue growth to be higher for Medicare because we have a larger growth in the number of Medicare beneficiaries than we do in the population of the state. But we'll get into that in the per capita. But we're showing about 3.5% growth for the fiscal year, and a little bit more than 4% for the calendar. This is not our official monitoring test. Our official monitoring test is payments, but we have a lag in terms of payments, and we get that information directly from Medicare, and we have about a 3+ month lag to get that data in. So hopefully in short order we'll have some fairly complete data for the calendar year 15. And when we convert those results to a per capita basis, what we see is that on a calendar year basis or a full year basis, the per capita growth for the all-payer is at 2.31, and the Medicare fee-for-service is at 1.13. And I want to stop and discuss that in particular, that as we came into the year and we were setting our expectations relative to the rate increase that we were focused on and testing to see whether that would produce the Medicare savings that we hope to produce, we made an assumption that there would be a difference between the all-payer per capita number and the Medicare fee-for-service number of 2%. So meaning that we thought that Medicare fee-for-service growth would be 2% under the all-payer per capita growth, and that was based on some historic analysis. And so what you can see is that we didn't actually achieve that different statistic, so that relative to our all-payer growth, our Medicare growth was higher.
Can I ask a question on that? This, again, you referenced the fact that this is not the data that's used for the test, where you get the payment data from Medicare. Can we, I mean, I would think that at this point we, at least for the first year, calendar 14, fiscal 15, we would have final or pretty much close to final Medicare data, so where we could compare the per capita or per beneficiary growth rate that you're showing here to what's coming through the payment system, to at least get some idea of how reasonable it is to use the 0.64 and the 1.13 that you're using here, by going back and looking at what that relationship was to using your charge data versus using what's coming through the Medicare payment system.
So I think, I think it may be feasible for us to even use the figures through December 31 and look at those figures at next month's meeting. So I wouldn't want to lock in an idea or a thought process without looking at that. So we should be able to, even though it's not official, we should be able to at least use it in our thinking process to see where did we end up compared to what the target was, and how does it show up in the numbers.
Right.
Things don't exactly won't exactly match up because of Part A, Part B, and the deductibles and coinsurance, and et cetera and so forth. But we can definitely see how things line up in terms of where we end up the year.
Yeah, I guess I would like to try to do that, is to get that out to everybody as soon as possible, because I think for me, I know at least for the first calendar year, the data that I recall was an all-payer growth rate that's been published of 1.47%, and a Medicare spending growth rate for hospitals that was a decline of just under 1.1%. So that would show a 2.5% differential for calendar 14, which is much higher than what you're reflecting here. So I just want to make sure we're using the most current and accurate data here, and not use this information, if it's incomplete, to drive decisions about where we go with the update.
And we will not have figures that we can use until the end of the month. So at March 31 is more or less when the figures come in, and we should use them, even though they may change, and they're subject to the federal government audit, et cetera, and so forth. But we should use them to make sure that we're correct in looking at the figures.
Just a quick question.
And I want to say on the 6-month figures, I've looked at growth rates on a 6-month basis, and you can't use 6-month figures. You have to use the 12-month figures. You could use prior 12 months, 6 months, and add them to these. But Medicare has higher utilization in January through March, because that's when a lot of people are sick with winter-related illnesses and in the hospital, and so we have to have the winter months in any formula in order to compare those annual expenditure rates. So I did just want to point that out in case you were wondering about that. Were you
I just had a quick question related to Mike's point. When you have the Medicare, the payment-related data, will we also be able to see the national data for the same period of time, so we get a comparison to how Maryland's doing?
Well, that's really what we would drive it off of, is the related data in comparison to national.
Right, but also, Mike, to Mike's point, the data that you get, the payment data is going to have, for Medicare, will have both in-state and out-of-state, so you could see how that relates to the all-payer to get a more accurate difference statistic calculation, I'm assuming. So I think that was partly his point, but so we could see both those, that'd be great.
Yep. Yeah. We'll focus on making that available in an appropriate format with all of the caveats. And in terms of other information that we provide to the Commission, we discuss the per capita growth rate compared to the 2013 year, and one of the things that we've done for the Commission is also to show what the growth rate is with and without rate adjustments that are made for uncompensated care and MHIP. So basically, the reductions in revenue for uncompensated care don't come out of the hospital's bottom line. I mean, that's the federal government also made large adjustments for reductions in uncompensated care through their DSH adjustment. So I don't want you to think that we wouldn't count those, because those are actually an incredibly important part of savings in Maryland that are also being addressed on a national basis with Medicare. But we do calculate a 2-year rate, and as what we see from this chart is that Maryland is well below the 3.58% per year growth cap, with or without the MHIP and uncompensated care adjustment, and there's also a we can also see what the Medicare increase is from the base, the 2013 base. Again, I think in order of looking back at the 2013 base, we need to kind of look at the actual Medicare data from our payment monitoring to get an accurate comparison to the test, but it's something that we do present monthly to the Commission. One of the other things that we monitor in addition to hospital spending for Medicare is the total cost of care spending for Medicare. And in this calendar year, and we have a bit more of a lag on non-hospital spending because the billing and payment process is slower than it is for hospitals. We have data through September of 15. And what we have been seeing is that there has been an increase in spending outside of the hospitals. And part of that spending is in Part A, which is primarily the post-acute services, in addition to hospital spending. And there is also an increase in Part B. And so this is and so we have a chart here below that shows you what the increase in spending is for the non-hospital Part A services, and actually shows some hospital services as well. So that what we're showing in terms of the non-hospital service increase is a 3.7% overall increase in spending per beneficiary. So we also compare that to the national rate of increase, and we have in particular started to focus on the skilled nursing facility expenditures. And what we have seen, and I'm not going to spend an intense amount of time in this meeting. We are having a webinar to go through some more of these details. But in the upper right-hand corner on Chart 2, what we can see in particular for skilled nursing facility is that there is an increase in total expenditures of about 5.4% in Maryland, whereas that figure is 0.3% growth nationally. And when we turn it into a per beneficiary calculation, it's a 2.4% increase in cost per beneficiary in Maryland versus a 0.5% increase in per beneficiary nationally. So that we're actually having some DSH savings on the non-hospital side. And so that is going to be a concern if it undermines our hospital savings beyond a certain percentage point. So one of the things that we'll be doing in the short term is providing detailed information to those hospitals who have increased referrals to skilled nursing facilities or whose referral facilities have increasing lengths of stay or cost, and ask hospitals to begin to look at that information and help us understand it and understand the implications. Kristen?
Yeah, do we have an idea? I see here you have the growth year over year, but do you have an understanding of what the use rate for Maryland versus the nation was? Were we underutilizing before and now there's growth because we're getting right-sized, or do you have that information?
Well, I don't think I would tell you that the federal government does not believe that there is an underutilization problem in skilled nursing facilities. It's one of their top areas for reduction in terms of potentially avoidable utilization at the federal level from practice variations and long lengths see and excess referrals. Maryland is just right about at the national average on SNF. For home health, it was below the national average, and for hospice care, it was well below the national average, but the SNF utilization was right about the national average. Okay. So Stu looked like he wanted to make a comment.
I was going to ask the same question because one would expect if Maryland started below, I mean, it looks like they were about average in SNF, so that wasn't the case. But if Maryland was below, was more hospital-centric care than the rest of the country, then you would expect that more attention to the appropriate site of care would shift some services over to post-acute care. But if they started out at the national average, then that means there's still work to do.
Yeah, I think there's definitely work to do on the SNF side. The home health and hospice increases are not as much of a concern. However, we still need to make sure that when we reduce the hospital costs, that we reduce them enough to offset any increases on the other side, so that we achieve the savings that we promise Medicare, regardless of what services are being shifted into another setting. And also there are choices. So hospitals could choose to utilize home health services that are billed to Medicare for implementing care coordination, or they could pay for care coordination out of their own resources. There are some choices there. And if they choose billable services as the avenue, then we assume that they'll need less money in their GBR to pay for care coordination services. So that's not a description of this one's right and that one's wrong, but we need to pay attention to that in terms of how monies are provided for care coordination.
Donna, so in summary on this, it's great information that you presented, but as I read it, then I see this as kind of good news, but there are clouds on the horizon that we need to focus on. Is that an accurate reading of this?
So basically, as we've been monitoring, we are still ahead of what we told Medicare we were going to save, in spite of the growth in the non-hospital costs. So we have not failed to meet their expectations. We're more than meeting Medicare's expectations in terms of savings. So that's, but we do have the non-hospital cost growth, and so right now it's not that additional cost growth in 2015 has not produced additional hospital savings. So the hospital savings are still intact from 2014. However, the non-hospital savings increased, and we have not yet seen any reduction related to that in the hospital costs. And so that's a concern if you're investing more money in post-acute care, but you're not seeing a reduction in the hospital side. So if we saw the reduction in the hospital side, we wouldn't be concerned about it, but if we don't see a reduction, then we're concerned. So that's really the conversation that we want to start having with the the hospitals and the industry about the increase in the non-hospital side. Does that make sense? So if you're going to make the investment, you're hoping that the utilization goes down in the hospital and it offsets the increase on the non-hospital side, which it happened in 14, but it didn't yet happen as a result of 15. So now we're headed into talking about the annual update process, and I think Jerry's going to pick up here.
Thanks, Donna. The one thing that we wanted to do this year is provide a update that would generate some discussion. So while a lot of you, I'm sure, have looked forward through this packet to see where the numbers were, you'll see that all the blanks weren't filled in. So we wanted to generate a lot of discussion through this presentation today. But some of the goals that we need to consider when looking at the payment policy is one is to meet the all-payer requirements and support the waiver and the triple aim. This is nothing new. Provide hospitals with overall fair and reasonable compensation for the services they provide. We've been trying to accomplish this now for some time. It becomes a little more tricky as the incentives and the aims change over time. We also want to ensure that we provide hospitals with rates and revenues that are sufficient, especially if they're effective and efficiently operating. We also want to ensure equity among all payers, and we also want to promote health quality equity. That's something that we're going to be trying to consider a lot more during this process. Some of the desirable features, again, is promote adequate information sharing between hospitals, payers, and the commission here. Promote cooperation and collaboration amongst especially hospitals, but also with payers. To provide sound value incentives, not only from a price standpoint, but also from a quality standpoint. We want to provide hospitals with the appropriate incentives, depending on what we're trying to accomplish today. And we're trying to consider any other requirements that we think are reasonable during that time period. So some of our key considerations in going through this will be compliance, again, with the all-payer and the Medicare guide rails. So while Donna's presented information that shows we are doing quite well on the all-payer results, our Medicare results aren't as good as they could be. We will definitely be concentrating on the expected growth in Medicare hospital rates, and we'll look to be providing some incentives that will help us reduce those increases. Again, we're going to be looking at inflation overall, and then we're also going to be looking at some individual inflation issues, especially regarding supplies and drugs, or medical, not necessarily medical supplies, but more or less drug cost. We know there was significant increase in drug cost over the last few years. They seem to be more moderate today, but there are significant increases in costs associated with certain types of new drugs that are coming onto the market, and we want to be considerate of that. We're also going to be looking at trying to ensure that the money we distribute for population and demographic adjustments will meet the needs of the hospitals serving those communities. We're going to be looking at the financial condition, again, of the hospitals. And currently, the hospitals, for this fiscal year, the regulated profits are in the neighborhood of about 6.5%. The overall operating profits are somewhere around 2.8%. And while that sounds good, we have to ensure that the hospitals do have reasonable profits. We're going to look to provide incentives to hospitals, and we're going to look for some shared savings during this process. Again, we're going to try to account for any unforeseen adjustments, and we know they always come up every year. And then we'll also look at other things such as categorical exclusions and transfers and how they're impacting the cost of the change.
Jerry, just one comment. On your goals to guide payment policy, we talk about, the all-payer requirement and these others, but I think we should also have, as part of the payment policy, the Medicare savings target. You got that as like other key considerations, but I think we've used it in the past, and I think it should also just be stated as part of the payment policy.
Okay. We can include that in there.
I mean, this was something that we spent multiple meetings discussing in, I guess it was as we were implementing the model. So
It wasn't included then?
these are the things. This is the way that it came out from that discussion of the model at that point in time. So I guess. I mean, I think the all-payer model requirements include specific requirements for Medicare. There's, the four.
When I look at that, I think of the 3.58 versus the Medicare trend less 0.5%. So, I mean, if that's the intent of it, I mean, it probably wouldn't hurt just to include it.
Just to say that it meets the all-payer model requirements. So to make sure that we're talking about the model requirements, which includes multiple provisions. It includes quality provisions. It includes savings provisions. So that, yes. So I think that seems like, is that an okay clarification? Does anybody have a problem with just restating that in that manner, or
I have no problem with that.
Okay.
Okay, so as I've pointed out, we were trying to generate some discussion with this next schedule, and I just want to tell you too that these numbers we've been looking at what's going on nationally and with Medicare. The IPPS numbers are not out yet for this year. They will be coming out in the preliminary numbers will be coming out in April, but we're looking at this and trying to take into consideration what's happened in the past as well as what we expect might be happening in the future. So just to reiterate real fast that the maximum all-payer amounts is 3.58. We expect population growth to be 0.52% this year, so the maximum revenue allowable growth would be approximately 4.12%.
I'm probably going to do this as you go through each line.
Sure.
Because there's a lot of information here where there's no, if you will, backup calculations. So if you can share with us, for example, on the population growth, I know we get that from the Maryland State Department of Planning, what that data shows, and how we came up with the 0.52. That would be helpful.
So, I mean, it's the most recent growth rate, so that's basically what it is, and we can definitely document the sources of the information.
Yeah. Okay, and that's what I'm looking for, because I think I've looked at what's on their website, and they have a projection for 2015 through 2020 for population growth for a 5-year period of time, which would be a larger number than this. So I just want to make sure we have that information from us.
Yeah, I think what and we can get into it some more, but what we saw is that they've decreased the population growth estimates, but they have not changed the 2020 number, but they have decreased the growth estimates for the state. So when we started out the model, we started out with the 0.7, but then they decreased the growth estimate down into the, I think last year it was 0.56, and this year they decreased it to 0.52. So so all of the evidence that we have so far based on the information is that their growth estimates are in this point, in the mid 0.5s and not running up in the 0.7% range. They've decreased the actual growth estimates on a current basis, but they haven't updated their chart for 2020. So even though we had declines in population compared to original estimate, they didn't update the 2020 chart. So right now we're looking at the most recent estimates.
Okay, Mike.
Just one thing. Is any of this, are we just taking the pure population growth or change, or is there any adjustments for where the type of population? Is it, is it more Medicare? Is it more middle-aged? Is it more younger people? Because that does have an impact on spending one way or the other. Are we looking at that just to make sure that it's consistent?
Our waiver is just based on an unadjusted population growth, so that's what we're using.
But we do take different things into consideration when determining what the growth rate is for it. I mean, we do look at demographics of the population that you're serving too. So, I mean, it's not just a straight change in population, if I'm correct.
Well, the maximum allowed growth rate for the all-payer model is the 3.58% plus the population growth. So it's per capita spending, all-payer per capita spending.
So we look at these different things and then we adjust it to the overall growth rate that's allowed for the state. So that's our constraints are on an all-payer basis. When we start looking at this, we tried to get an idea of where inflation is going, and we have realized that over the last 2 years there's been a fairly significant difference between what the estimates are and what the actual turns out to be at the end. And again, we've seen that 2 years in a row now. We didn't want to take into consideration the entire difference at this time, but we do think we need to take into consideration some estimate, give some weight to what has happened in the past. And so we've looked at what their estimate is this year. We've looked at the difference between what the estimate and what the actual turned out to be, and we are making an adjustment similar based on that. We think that the overall amounts we should be providing is about 2.1% overall. Of that 2.11%, we believe that we should possibly have a holdback of about 0.2% to provide the hospitals that are experiencing large increases in new drug costs. Especially, I believe, it is for oncology hospitals that have oncology programs where there's new drugs coming onto the market. These drugs are very expensive when they first come on the market. We believe they would have some cost pressures that would be greater than those that don't have those types of programs. So trying to take those types of things into consideration at this point in time, we think might be important. So we've had this set aside here for that. We've also believed that we need
Jerry, before you get to the next one, again, because you've combined a couple of things here. Okay. All right. You suggested you're building in some kind of forecast error into this. So I'd appreciate it if you can give us the calculation and the historical data behind which you've calculated a forecast error, and then so that we have first what Global Insights is showing for their projection for the next year, then what you're showing is the forecast error that nets down to this 1.91%.
What we've looked at is the last 2 years, we've provided, the estimate was 2.4%, and inflation actually is running about 1.8%. That's about a 0.6% difference, and we've just said, we're going to take out half of that possibly and look at around a 2.1% increase at this point in time.
At least that's what we've written down here, right, in that, and as a discussion topic, and just trying to figure out the the aspect of forecast error. There seems to be a pattern to it.
Yeah, I'm trying to understand the point too. You're describing it almost as if it will be a hospital-specific adjustment. Is that the intent?
Yeah. So, in terms of what we were thinking about is to take some money out to provide a, I'll call it a pool for new drugs, and not 100% cost pass-through, possibly a 50% cost pass-through on new drugs for a limited period of time while they are getting built into the base for the hospitals, or the ongoing base. But we've been seeing some new medications come into the market. It's something that's expected to continue. And so as those medications are introduced into the market, we need to make sure that people are considering the cost effectiveness and the efficacy of them, but also that we're setting aside some, this is a proposal to set aside some funds for those drugs while they're coming into the marketplace. And the oncologists in the state have made some specific comments about making sure that the access for those new drugs is taken into consideration in the global budget model. And so this is a one thought about how to do it. The federal government has some other things that they are starting to consider, but and we certainly don't want to carve out and pass through all drug costs, but this is to set aside a relatively small pool for new drugs that would allow a portion of the cost of those drugs to pass through for a temporary period of time. A portion of the cost is covered in the population adjustment because the population adjustment considers aging, and a portion would be considered in inflation. But we don't have a different approach for hospitals that provide the service versus hospitals that don't. And for now, that appears to be creating some difficulties with the drug cost. And so this is a thought process of a potential proposal to set aside a pool amount to provide. If the actual use was above the pool level, then it would be a distribution of what was in the pool once we fixed the pool. It wouldn't be a guaranteed cost pass-through, right, but it would be an intent to set aside some funds to help ease the use of new drugs into the marketplace.
I have a couple of questions. First, am I to understand that the model allows for a revenue growth both for based on the economic growth of that's the 3.58%, and inflation 1.91%?
No, the 3.58 is the maximum growth that is allowed.
So you're starting from ground zero.
We're saying
1.91.
We're not even guaranteeing that. That's
Gotcha.
the ceiling.
Okay. I just want to understand.
The folks in the room would be happy for that to be a guarantee. Quite honestly, we probably
plus a catch up on the first 2 years as well.
So
we probably wouldn't be having a meeting if we were all happy with that number as a starting point.
I'm pleased to know that. and secondly, on the high cost new drugs, I'm somewhat sympathetic to the hospitals in that situation. Our plan in 2014 experienced a $5 million loss on prescription drugs, mainly due to some of the new drugs that were coming in. But what we did was we switched PBMs, we renegotiated our contract, and our costs from 2014 to 2015 actually went down. So my question is, what options are available to hospitals in terms of how they negotiate and buy drugs, and if that's been given much thought? And
So this is not retail pharmacy. This is only a small portion of Part G,
No, I understand
Part
exactly
B
what it is.
administered drugs.
We pay for that too.
I know that. And so, so right now we have really no cost pass-through. It's all under the cap. And so, and this is an attempt to really bring a relatively small portion of the drug cost out from under the cap on a temporary basis while the drugs are being
No, I
introduced.
understand all of that. My question really is directed, you know, you've done a lot of stuff, I think, to kind of encourage care coordination and other kinds of things that manage cost. And so is there...
The oncologist, and, you know, I think there needs to be an ongoing discussion, but in the state oncology meeting, the oncologist suggested that patients should be given at the time of potential service information about the cost and efficacy of the drugs that they might be using, so they can make decisions about whether they want, not just efficacy, but side effects and the impact on their life and longevity, and so that they can make informed decisions about whether they want to undergo treatment with those drugs. And so there was that was a recommendation out of the oncology group, and I think there have been some good efforts in the state with the oncologists who have some of the oncologists and some of the institutions have decided that certain drugs really don't have a good benefit to the patients, and they have excluded some of those from their formularies.
So that's the kind of thing I'm talking about.
But the HSCRC doesn't really step into that territory, and that's really the territory that we want the medical professionals to really drive that conversation, and not the HSCRC. So it is I think the oncologists were equally concerned with the rising cost of drugs. A lot of the policy has to come from the federal level, because the federal government's cost reimbursement system is what's driving the high cost of drugs in the United States. When they set cost reimbursement and they don't set any limits on it, and the drug companies decide what the cost is, the results of that are going to be obvious. It's not going to be a good picture. So a lot of the policy has to happen at the federal level, but they also recognize that there are things that they were recognizing in the conversation, that there were things that they needed to do to make sure that that they were looking at whether some of the high-cost drugs provide value. They found that many of them did, but some of them didn't. So that was I'm just giving you the fast rundown on the conversation, but so it's an item for discussion in terms of thought.
Donna, so there will be, I guess, you know, this, I think one tendency is to get confused between what I'm calling the above-the-line calculation, which sets the limit, and now you're talking about the components of the actual rate increases that you're setting. So that, but this 0.2% pool, will there be an explicit algorithm for distributing that money? I mean, is it?
Yes.
Okay.
So I mean, we have.
And if not all the money gets distributed, it doesn't go back in the rates.
It could go back to the next year's pool to decrease the amount of funding that had to be set for the next year's pool. But I mean, that would be one potential. So, yes.
Can I ask a question? You know, you've indicated, Jerry, in doing the forecast error projection, you know, 0.6%, that was done basically on the overall number, not the number excluding the drug costs, correct? Correct. Right. Could we calculate the forecast error has been for drug spending going back? Because it would seem to me if you're going to subtract that pool out, that you very need to see whether the 0.2 is even close to being adequate for what historical underspending, under providing for the actual cost of those drugs has been for the last couple of years.
Yeah, I don't think that isn't supposed to be, that 0.2 isn't supposed to be for all drug cost increases, because that would be a much larger number. You know, that's not intended to compensate for all drug cost increases. I mean, we can also debate the size of it. I mean, should it be smaller? It's under the outpatient prospective payment system, the federal government has a small number of drugs that it provides a pass-through status for. The rest of them are under APC. So it's really not to compensate for growth in drugs that were already there or inflation on those drugs. It's to really focus on drugs that are being newly provided. And so it should be thought of from that perspective.
Okay. Just to continue then, the next thing, though, that we want to do is to set aside some money to provide incentives to hospitals to implement population health initiatives that we think are important for the future. We've provided lots of money to the hospitals in the past for the population health, and we want to ensure that they're initiating and putting into place the things that we think need to be done in order to further those goals. You can see there's 0.25% withheld for each of these three different things here. The rising risk for community-based providers is one. Providing incentives to treat complex patients for regional and community on a regional basis and with community partners, and then also to look at long-term care and post-acute care and provide incentives for hospitals to work with those people. And so in total, it's 0.75%. The idea would be to provide this to the hospitals once they've shown they've put these things in place in order to impact what we're trying to get done. The next thing is the component is the volume adjustment. I figured I was waiting for you.
Well, you're going real quick, Jerry. So what you're doing is taking out of the all provider, all hospital inflation increase 75.75, and then saying that on a hospital-specific basis, you'll then give out as much as that same 0.75, depending on a series of programs that have to be demonstrated to be in place on July 1st. Do we know what those requirements are? Will we know between now and July 1st what you would define as a successful implementation of rising risk programs, complex patients with regional partnerships, long-term care, and post-acute? Is there a predefined set of requirements that our hospitals can know about now so that they could potentially have them, if they don't have them in place, have something in place by July 1st? Is that the intent?
I think the intent of bringing the discussion to bear is that we have the ACA adjustment. We don't have the full inflation adjustment yet for IPPS, but we know that ACA is going to take out a very large negative adjustment of 0.75%, I believe.
Right, but that works into the Medicare savings calculation.
And so the way our model works is that the way we say we want our model to work is that if we can implement care improvements faster in Maryland by having care coordination activities or other successful implementation. That successful implementation of care improvements may be able to provide enough savings to make up for that otherwise adjustment, and so that's the basis for the discussion point here and the presentation. And so you know, we've had a number of conversations throughout the year about potential programs and potential definitions, and in terms of successful implementation, if we were providing a rule set around successful implementation, we would have to decide that successful rule set. So we have not put out a successful rule set for that as of yet, and quite frankly, it's possible that folks might not be ready on July 1, but they might be ready on January 1, and so they might be able to get their increase on a different date than the first day of the year. The issue is that we really need these programs up and running in order to drive the success of the model and to reduce the avoidable utilization.
So the minus 0.75, as I understand it, is, if you will, a set aside in anticipation of a lower national Medicare spend. That's what you mean by an ACA savings, that when you get the IPPS update nationally, you're expecting it to be about an offset to market basket of around 0.75%.
Yes. Actually, let me just say a specific ACA adjustment. So historically, we always offset a productivity adjustment, and so we said when we came into the new model, we hope that Maryland can produce reductions in avoidable utilization and contain growth in volumes by being on a new system. And if we're able to do that, then we will hope not to have a productivity adjustment also. The ACA set into account savings adjustments in addition to productivity adjustment. Last year, I think the number was minus 0.3. And this year, I think it's going up to minus 0.75. But the IPPS stuff will come out at the beginning of the month, and we'll be more certain about that. So there's a productivity adjustment and an ACA adjustment, and so we're saying there's going to be an ACA adjustment, and we need to make sure that we're getting our programs implemented and being able to have the care improvements that drive the avoidable utilization reductions that will allow us to also produce savings for Medicare.
Donna, just a quick question. If when the IPPS update comes out, there are additional offsets in the recommendation, is it the Commission's plan to mirror those additional offsets? In other words, if it varies, it's less than 0.75 or more than 0.75.
Well, we know there will be a productivity offset, and so we don't have that here. We know there's a coding offset. We didn't have that last year, and we didn't have that here. We knew that we had to produce with a new model an approach that gave us the per capita spending that we were focused on achieving. So that's what we focused on with the model, is achieving the per capita spending that would provide the Medicare savings.
Right. So we just wait to see what the IPPS is with whatever the adjustments, and then that will lead you to finalize this. Is that
will help? It's not the only factor. There's this other thing called volume. So the IPPS is a price estimate, but there's another thing called volume, And so the ultimate question is what happens on the volume side, on the federal side, to produce a per capita spending, and then what assumptions do we make, because we're focusing on price and volume in one big package here. It's all together, price and volume, because we have a global budget is based on the federal government's desire to create models that move away from paying for volume. We have a model that does that. One of the most extensive model that's actually been implemented in the country right now is this model. And so we're trying to navigate how to measure the price and volume components. So it's not just the price, it's also volume.
One just quick question. On these coordination and this allowance, is there a sense of what, in terms of gain sharing with physicians, I mean, that is incorporated here, and do we know to what extent? In this 0.75% and the care coordination allowance here.
So we are not going to provide money in hospital rates to pay gain sharing. I want to say that because gain sharing means you actually saved money, and then by having savings you could pay it out. So we're not going to increase rates to allow payment to physicians for gain sharing. So that's not in the money. That's the allowance there is, those figures are really just focused on, do we have programs implemented that could be expected to perform? So that's really what the notation is there, and is subject to discussion.
I guess it would include not gain sharing, but care coordination models with physicians, not gain sharing.
Yes. So the actual work of care coordination would be with physicians. So that the first two line items are heavily with physicians. Even the long-term and post-acute really involves physicians. Some of them might be SNFists. Some of them might be specialists helping to follow patients through the post-acute setting. Some of them might be working with the orthopedic surgeons to decide when a patient needs to go to a SNF versus to seek services at home from a home health provider, for example.
Thank you.
On the 0.75%, is that in addition to the 0.25% for the grants that was included in the 16?
No. So I think that would be if we're having successful implementation, that would be inclusive of money that would be provided under those grants. It doesn't say must have. It doesn't say July 1. So if you were going to get a rate increase, what we're discussing is you can't get the money in rates until you have the program in. Not if you have it in on August 1, you can get the money in on August 1 or September 1, or
Actually, Michelle, sorry, can you use your microphone, please? Okay, I'm just curious, is it the hospitals and their outreach for the care continuum that you're interested in here for a program that's in place, or is it more formalized?
So just for example, if we have 25 to 40,000 complex patients in the state who need care coordination, do you have a program in place in your hospital that has your proportion of the 25 to 40,000 under active management. Not that you're just thinking about the program, but that you're actually doing it and that the patients are actually being managed. And then the same thing with the rising risk patients, which is a larger set of patients, but clearly you won't be successful. You need to work with community partners in all of the programs, but particularly with rising risk patients, you wouldn't be successful if you didn't engage primary care and other community providers in dealing with the rising risk patients.
I think I'm just asking, what would you want hospitals to show you that demonstrated that they did have that in place?
I think we have to define that outside of the room here and
okay, so that's still a work in progress.
Give it. I mean, we've had a lot of conversations about it. We've done some definition about it now in terms of implementing this type of a program. Then we need to give you more specific measures and how we would determine whether you were in a fully implemented stage or partially implemented stage.
Right. But earlier, when you talked about the things that we're working on, the amendments that we're seeking, clearly, I think we've agreed that the tools that hospitals need to do these items requires first the data, and then second, we've suggested that to do a lot of these alignment activities successfully and to implement them successfully, we need the ICS and P4O programs, and those amendments are not yet approved. Seems to me then it's highly unlikely, A, without the data, and B, without those programs approved and in place and those incentives aligned, to realistically expect hospitals to have substantially implemented any of the programs that you're anticipating here.
Well, I disagree with that. I think the long-term care and post-acute care programs can be implemented now. I don't think that's hard to figure out in terms of where the activities are coming. The complex patients can be identified from hospital data. There might be an improvement in the identification of complex patients when we get additional data, but we definitely have plenty of data to identify complex patients. Even with the rising risk patients, there are opportunities to identify rising risk patients with hospital data. It will be improved with the addition of data from the Medicare data set. However, there are existing data and there are existing approaches that can be employed for all three of these areas.
So you're talking these 0.25% numbers, you're talking about basically hospitals, if they show you that they have successfully implemented programs in these areas, that they will then get a 0.25% increase in their rates based on each of those categories, right? Is
that's what we're discussing.
Okay.
So we're discussing that as an option.
Okay. So rather than a pool of money that gets distributed on some other algorithms, this is basically a checklist. Yes, I've shown you that I've done this program successfully, and so I qualify for this additional update.
Right. So basically, the commission staff believe there's been uneven implementation of some care coordination programs, and we would like to see more even implementation. And so we're hoping that if we actually have a formalized process to make sure that we're implemented, that would be in everyone's interest. It would be in all of the hospitals' interest, and it would be in each of the hospitals' interest to have a program that makes sure that we're all getting implemented, because we're all counting on reductions in avoidable utilization to balance the model, and if we don't get those, then it has an effect on everyone. So it's an attempt to think about it from that perspective.
And just so I can describe this to my members, so the minus 0.75 is in essence until we have the programs in place that show the things we'll be doing to reduce that avoidable utilization. We're going to reduce rates for all payers by that 0.75%.
Which is the ACA savings adjustment.
Which is just for Medicare.
It could be.
Well, it is just for Medicare.
Well, the Medicare's implementation of that is just for Medicare.
Correct. All right. So what we're saying is we're driving the all-payer update based on what the ACA is doing just for Medicare.
Well, in other states, the commercial payers have savings programs, and the Medicaid folks have savings programs, and they make adjustments too. So in this particular instance, that is entered here as a proxy for all payer savings estimates. And many commercial payers use the IPPS net update for their allowance calculations based on my work experience.
Well, if you could share that data with us and then share the data with us that's showing what the all-payer payment growths are in the other states where they have no cap on volume and case mix like we have in this system. I think you'll have to show that to us as well.
If I understand what's going on, you're taking out 0.75% that would be applicable to each hospital, and you're putting it in a pool that some hospitals can draw on. Is that basically it?
All hospitals can draw
on it.
But
I mean, in reality, maybe some will and some won't. All hospitals can.
All hospitals who implement can draw on it.
Right. All hospitals can, but maybe not all will. So therefore, that's why I said some.
Maybe it would be useful to think of them as two separate numbers. The 0.75% is basically because of the ACA, it's likely that the bar Maryland is going to have to meet is going to be more difficult to meet because nationwide you're going to have these changes in policy. And then the 0.25, 0.25, 0.25 is basically a statement that in order to help hospitals Maryland-wide meet these policies, that there will be some. It turns out it's the same number. It doesn't have to be, but that money will be devoted to targeted efforts that will help Maryland hospitals meet the targets.
Yeah, but Stuart, the problem is we're only looking at this on a one-year basis.
Yeah.
All right. When in fact, the way our agreement is written, it's on a cumulative basis.
Right.
All right. Because I could argue that in 2 years, the coding offset that's occurring in the national number, all in one, it starts to get paid back in future years. And so that there's a substantial reduction now for something they're going to pay back in future years. We ought to include that and look at that on a cumulative basis. And I can guarantee you that if we do this on a one-year basis, if there's a big bump up in Medicare in a future year, because they're starting to give back some of that coding take back, I can guarantee you we're not going to come here and pay more than 3.58% to give back that extra 0.75 or multiple years worth of coding increases that they're going to pay back. That's in statute. That's in the ACA, right? So that's part of this perspective here. We need to look at this a cumulative basis. The fact that next year Medicare may lower the number does not offset the fact that on both an all-payer basis and a Medicare basis, cumulatively, we've far exceeded where the savings were required for the first 2 years of this agreement.
So Donna, I have a question and a comment. Does a hospital have to spend any new net cost in order to get the 0.25?
I would say not necessarily. If they're actually managing all of the patients that they need to manage, and they've already spent the money and implemented the programs, and now they're starting to get them up and running, and they get them up and running, then what we're really wanting is to make sure that people have successful programs for the care coordination. So it's not necessarily about money as it is about successful implementation.
So just check the box. Check the
I don't
box
know
to
if
make
check
sure.
the boxes.
Well, check the box to make sure all those processes are in place.
So that we have we won't be successful in reducing PQIs if we don't have a chronic care program. We won't be successful in reducing, ultimately in reducing readmissions to the level we need or avoidable admissions if we don't manage the complex patients better. And the patients won't get the better care that's promised under the model unless we do those programs. And we won't get the 70% of admissions reduced in the long-term care setting that are possible based on the literature and on some experiences that folks who have implemented are already having. We won't get that unless we actually implement the programs. And we won't have effective post-acute care being provided if we don't focus on the best place for patients to get care and making sure that the length of stay is appropriate in those facilities.
So thanks. My comment is a concern I have. I can't help but, having been around a long time, see the correlation between the success we've had under the waiver in the first 2 years, which to me, kudos for the whole industry to make that happen. I can't help but notice a correlation between that and the opportunity given to the hospital during those 2 years not to be focused on just cutting costs because we had to make up an update factor. And I think that the reason we were successful is that we got healthy update factors and we could begin to plan focus on the future. My aggregate concern is, as we keep chipping away the basic update factor, put any tagline you want on it. But when it's all said and done, you're going to see providers shift back to what we were doing 3, 4, 5, 6 years ago of hunker down and see if you can keep from losing money. And I'm worried that the focus just may not be this long road that we're on. So I would just caution everybody to not think in these 1-year increments, but think about what's been accomplished and what were some of the key dynamics. I'm concerned, so that's my only comment.
Yeah, I think it's a really important point, Hank, that we really need to keep folks focused on the opportunity because it's a tremendous opportunity, and the implementation has been successful. The Medicare implementation in the second year needs a little bit more push, and I do have a concern. You have a concern that people will hunker down. I have a concern that people will hold on to the money and not make the investments that they need to make to reduce the avoidable utilization. And so personally, I would like to see healthy updates, but I would also like to make sure that they're getting invested so that we can achieve the benefit for the patients and the reductions in avoidable utilization. So just to make sure that it's actually happening and that people aren't hunkering down and holding on to the money. Because there is a tendency when people are comfortable that they don't move forward, and so people get comfortable if their profit levels are better. Do they want to move forward to the next step? Can they, what do we need to do to push forward to make sure we get to the next step? So how do we address the concerns of making sure that the the investments are made and the infrastructure is put in place by the provider community that we need to drive the model forward and that we need to present to the federal government as our phase 2 strategy. So, this is a big part of our strategy of getting better care to the patients, of moving the model forward.
And everything I learned, understood about transformation like this, it takes many, many years. And I think we have been building a good platform, and I am concerned that we're rushing to judgment here, and there's no reason to. We ought to keep this positive momentum going, and I think it's been very positive, and I'm worried about this wrinkle here. Your point is understood. I think we got to find that balance.
If I could make a comment to that, I agree with what you're saying, Hank, and what you're saying, Donna, because I think we are trying to move the dot, in general for the entire waiver. I'm wondering if the update is the right place to put the penalty versus all of the things we're supposed to talk about next within this agenda, which are the penalties. So, it feels like we're getting a little penalty added here to the update factor, and that does have a bit of a constraint on your thinkiness. I know Frederick's been one to really invest, and we haven't, as you know, worried about the bottom line as much as we've worried about moving the dot for the community. So when I see this and I think, money could potentially come back, and then you could potentially still have very high tariffs, if you will, on the penalty. It feels like that's an imbalance there. So I just offer that thought.
Well, I guess the, in terms of relief from the 0.75, the ACA adjustment and the productivity adjustments, what we have to balance in the conversation is, and so here's the conversation that is in my head. So the relief is because you can move fast enough to alleviate the utilization that will offset those adjustments. So that's the conversation on one side. We can move faster. We have this global model. We can move faster. On the other hand, if you start saying, well, we can't move that fast, then we have to go back to thinking about how do we alleviate the I can't move that fast. And so that's the balance that we have to figure out how to strike, is how fast can we move, and how do we express that in our update process. So there's, as you know, Hank, being the great accountant that you are, having gone to a wonderful school, Hank and I graduated together. Yes. So we have two levers. They're called price and volume, and there's only two levers, and we have to adjust those levers. So we're here for a conversation on how to adjust those levers in the current situation and to get the input from everyone on how to make those levers work with our situation of speed or not speed, speed, hurry up or slow down. These are the levers that we have to work with, Hank.
But I think what I'm hearing,
Frank's one too fast.
Yeah, what I think, though, I'm also hearing Hank say is the point I was just making earlier. I think how you view that balance also depends on this issue of looking at things on a year-over-year basis versus a cumulative basis. I think the folks that I represent clearly understood that this was a 5-year agreement that was going to take time for all of these activities to take root. In fact, the agreement, in fact, specifically says in the first 2 years, cumulative savings of $49.5 million for Medicare, and we've far exceeded that. That, to me, was a clear recognition even by CMMI that these activities take time to take root and to grow and to deliver savings. And so to the extent that we look at this on a 1-year basis, I think ignores the fact that these programs take several years and ignores the fundamental basis of our agreement, which was a multi-year agreement. I think that's the piece that's missing here. If we're only going to look at this every year as a one-year-over-year number, that any progress that we've made in the previous year or the previous 2 years gets ignored in that process.
I look at it, Mike, as we've been providing hospitals money over the last 3 years to implement these types of programs. And that's what we're trying to do, is ensure that the programs have been implemented. And so I think that's, and I think many of the hospitals have invested in these programs appropriately. But we want to make sure before we start putting a lot of additional money into these that we're moving along with the programs that we think the hospitals should have been implemented by now.
Well, just to clarify,
it's been 3 years.
Yeah, just to clarify, the infrastructure investment money is primarily really didn't come in until the second and third year, and fiscal 15 and fiscal 16, because we didn't finalize the global budget agreements for fiscal 14 until way close to the end of fiscal 14, even if the funding was there. But cumulatively, I think the point here is that even with that funding, those programs take time to bear fruit. And I think CMMI clearly recognized and anticipated that when they constructed the agreement with us. And yet we're expecting to have delivered that much, $240 million of savings in the first 2 years for Medicare, and then some. And I think the answer that we're looking for was when is that agreement going to be adhered to? I mean, if we're going to look at this cumulatively, let's look at it cumulatively. If it was a one-year agreement, then it should have been written that way. That's not the way it was written.
I look at it, you said looking for the fruit. I'm saying I'm trying to make sure that you've planted the seeds. And so, we want to make sure that you've invested properly in these things and that it is going to take some time. And I don't think we're saying you have to show us that these are the savings you have to show us. I think what we're saying is we want to ensure that you are investing in these things appropriately and that in the future we should be able to see the savings from these programs. That's, I think, was the main thing, that, at least the way I view it.
Something that would help me and maybe others would be to understand to what extent these programs have been implemented already. I guess I'm still just struggling with, are these programs mostly in place today, or are there things happening to make sure they're in place?
No. I mean, you can read the reports. That I think that's part of the concern that's being articulated, is that these programs haven't been put in place. There's more of an emphasis on care transitions, less of an emphasis on care management. Monies are being used for things that are not directly related to this. The evidence so far is that the hospitals haven't done a good job in reducing potentially avoidable utilization. You could see it from 13 to 15. And so there is a general perception of what Donna's mentioned, that the hospitals are tending to hold on to the money, not invest them directly in these care management activities. And I think, when push comes to shove, maybe they will, but that's the reason why there's a little push at this point.
So just to follow up, if I may, real quick. So how well is it understood and how much agreement is there which ones have and which ones have not? Because I'm thinking if there's general agreement, could more be done to make that transparent to the community, to the payer community, so the payer community knows who's investing in these programs and who is not?
Yeah, I might characterize the situation a little bit differently than Bob does, which is the glass half empty, glass half full. But I think
never very thirsty.
Actually, I think overall, I think we are quite happy with the utilization trends in the state. There's not. We should be happy that we have flat utilization in the state, and that we don't have an overall increase in utilization, which is apparently what is happening in many other parts of the country, is that particularly outpatient utilization in hospitals is still driving an overall increase in hospitalizations and volumes. And in Maryland, we've flattened it out. So that's a pretty good that's a pretty good accomplishment. I mean, you have to call that a great accomplishment. So, we haven't, this past year we didn't make as much progress on the Medicare utilization as we wanted to, and so part of that is that most of the hospitals were in a planning mode of figuring out how they were going to take it to a next level, and so now we need the planning mode to turn into an implementation mode. And some hospitals, I don't think we know exactly where each hospital is in terms of that transition between planning and implementation. I think there's different levels of that. So I don't think we know exactly where we are. All of the Medicare statistics, the inpatient admissions went down, so it's not like they didn't go in the right direction. They went in the right direction, just not as much as we wanted to see. So we are looking forward to a boost in the implementation this year, and we're hopeful that that will drive even more improvement, not only in the utilization, but in the quality of care for Medicare patients and in the amount of support that the Medicare patients receive. So I think it's, I'm thankful that the utilization is flat. We would have other problems in the state if it weren't. And now we have generated some investment dollars in the hospitals, and now let's go. That's kind of my view of the world.
So I have to make a comment. I think it's overwhelming to hear that somehow we have not done a good job. We're way below the all-payer test. We're doing extremely well on the Medicare test. We're learning new tools and things that we have never done before. Everybody, including the rate commission staff, is using consultants. It just takes time. Don't hit the brakes. Be careful. Don't hit the brakes.
I just want to say, on the physician side, I mean, I think everybody agrees that an amazing job has been done. But I think that the incentive for hospitals and physician community providers to get together now, it's the time. So I tend to agree with what Donna and the Commission are saying here, that the way this is set up will incentivize these care coordination models to move forward.
I believe it's going to happen anyway, because regardless of this withhold, to me, this withhold is a distraction. I'm a little worried about the message that's sent, because what you're describing, we all agree to, it's beginning. It's beginning. People are connecting dots here. They're developing relationships, and I think we'll look back on this year, and you guys will say, if we implement this withhold, see, it worked. And I'm going to tell you, it worked because the last 2 years have been the setup, and we'll see this progression over the next 3 years.
Yeah, and just to chime in again, I once again agree with the direction everybody wants to take this in. It's the collaboration, it's the time to get to the fruition of the ideas and the programs. I feel like, back on the volume price question, these penalties are dropping the price that you paid if you didn't get done what you needed to get done to reduce the and achieve the goals. So I still am uncomfortable that it's coming out here, and then it could potentially come out again. I do agree with Hank. We spent a lot of time trying to report, because we do put reports in. So just if we could spend our time continuing to evolve. This is a lot, in a way, a grand experiment for many of us. We keep putting in new things to see what will work. And we started off with a conversation this morning about habits. Complex chronic patients got there probably because some of their habits are bad and are hard to break. So as we get the first blush of the year's efforts and the results into that, this is now getting to be harder and harder, with more and more hands-on patient management, and that takes people, and that is a big cost. So that's what it's going to take to move the dot from our perspective. So I hope we show that in the results, don't get the penalty, and then but I do think that it's a little bit of a double hit here to take it out now and go have to justify it, and then spend time doing that instead of getting the programs in place that will end up, keeping us from reducing as fast as we'd like to. We've only got finite resources. I'd rather spend it on moving the dot.
should we try to finalize this, because we don't have much time left today, so.
Continue on. Continue on.
Yeah, again, let's just keep on going. We got another 0.52%. We want to provide for volume increases. That's taking into account the demographic adjustment, the transfers, categorical, and any additional volume that is generated through the market shift adjustment. So that's a 0.52%. We have a set aside of 0.5% again, like we had last year. We think that that might be used even more this year because we're moving towards trying to put together some type of full review process that I'm sure hospitals will, once it's completed, hospitals will start trying to take advantage of that. We don't have anything in place like we had in the past where we did spend downs, where we actually negotiated with hospitals where we thought they were higher, but that there may be some of that if things are really, but at least at this point we don't have anything in place like that. There's a 0.06% for workforce support programs. That's the providing jobs to areas where there's high unemployment rates. There's another 0.07% for Holy Cross Germantown growth. There's a 0.6% increase for reversing of last year's shared savings and a 1.1% offset to that. As you can see, we're going to provide positive and negative incentives, and we haven't put those things down, at least at this point in time. We haven't put down the total number, but one thing that we do have to consider is that there will be a reduction, we think, for uncompensated care for this year, and that should not have an impact on the hospital's profits. Uncompensated care rates at this point in time, it's 5.25%. Right now, it's running at about 4.9% or so. So we think there might be about a 0.25% reduction for uncompensated care. And then there's also the deficit assessment has also been lowered this year. That's another $25 million, and that's another 0.15%. So in total, about 0.4% decrease that we believe will occur regardless of what we provide hospitals here. So we haven't put any final numbers down here. The one thing, though, if we go to the next page, and we'll try to wrap this up real fast, is that we believe that Medicare growth, at least for fiscal year 16, is running at about 1.2% overall. Our savings goal has to be about 0.5%. That means there's a maximum growth rate allowed of about 0.7%. In the past, there was a 2% difference between the all-payer rate increase and the Medicare change. We're currently running at an amount that's about 1.27. Is that right, Donna? Is that the latest number? And so that would call for a conversion of about 1.98% increase overall per revenue growth that would allow us to meet that Medicare target. And that would convert to an overall 2.51% increase to revenue. So 2.51% increase to revenue would allow us to meet our Medicare target if all other things being considered remain the same. So,
and I want to mention one thing on that schedule, that has the Medicare growth for calendar year 2016 of 1.2%. The numbers that we've gotten from the Office of the Actuary for 2017 are 2.5%, and we're trying to understand that 2.5% in light of the IPPS update that we'll hopefully get to see next month, and asking for a breakdown in price versus volume so that we can understand how much of that is driven by volume versus how much is driven by price, so that we can make sure we know what we're dealing with. But last year we averaged the calendar year growth, and I know we had a actually it's at the top. It's a head note instead of a footnote. So I was looking for a footnote, but it says the 2017 figures are being discussed with CMS. So we're trying to see how to think about that 2.5% number. So obviously, if we put 2.5% into the formula, the all-payer growth maximum limit that comes out at the bottom of the page would go up. So I just wanted to make you aware of the fact that we'll be coming back to the next meeting with a report on our conversations about that figure.
And also the different statistic, that actual statistic, is based off of the one-year revenue number coming through the HSCRC system, not what's coming through the prior years in terms of actual per capita all-payer versus Medicare spending per beneficiary.
So we could have an update to line A and line D based on information that we get in this month.
Just on that point, could the staff provide just the information that they use to calculate and also some of the historical? Because you get I assume this is calculated from the Medicare data, because you get out-of-state from the Medicare data.
Are you
whereas
talking
the case
about
mix
line
data,
D?
I can't see if they're, well,
Line
yes,
D was
yeah.
line D was actually Dr. Cook's calculation.
Right, but the source data that you're using now to calculate the 1.27, I guess.
It was in the front of this section of the presentation. So
But do you have that back several years? I think my point is, I think the trend is also helpful to look at. And as I recall in Dr. Cook's original paper, what he did is he looked at the average over 5 years and went back, to a point when there were policy adjustments that shifted money from inpatient to outpatient, which affected Medicare. But because of that and other factors, he conservatively took a lower number. He looked at the standard deviation of the different statistic over time and then took a lower number. So it'd be worthwhile just kind of putting the actual trend in that context, I think, to see.
Maybe Dr. Cook would like to do that for us again.
I'm sure he would. He doesn't have very much to do these days, and after sunning in Florida, so yes, I'm sure you would.
We would be grateful.
If you provided the raw data, I'm sure I could.
Would be grateful for his valuable insights.
And just a quick question on this also, if I may. This focus looks on fiscal year, whereas the Medicare test is calendar year. And so our performance in calendar 16 is going to be a function of the fiscal 16 update here, which was quite flush, and whatever comes out in 17. So I'm wondering, is the Commission looking at sort of the combined impact of those two issues on calendar 16 performance relative to Medicare?
Knock on my door.
It's definitely a consideration. We did have some very good fortune, and some good fortune is better than the best calculation. So we had snow in January and we also had no flu.
So we start to look a little better.
So our January Medicare figures were 8% below January of the previous year, and we were very glad that it did not snow. We got hit in the opposite direction the year before. Let's be honest. We got hammered with the flu in 15. We got hammered, and we did not have snow, and they had snow, all that snow in Boston and New York that kept people out of the hospital last year obviously had an impact on the numbers. And so last year we had a little bad luck. This year, so far, we got a little bit of good luck. But that's just the first month of the year. So, we do, honestly, we do have to look at that, and it's part of the thought process.
Good, thank you.
Yeah,
sorry, Mike, but there are a few comments from online. I'm sorry we couldn't get to them. I want to make sure that they also have a chance to cut in. Stan Dorn, can you talk? Are you unmuted?
Yeah, sure. Can you hear me?
Yep.
Okay, that's great. I just wanted to speak briefly about the idea suggested by HSCRC staff, Don and Jerry, to set aside a portion of hospital budgets that would be reserved for making investments in community-based care management infrastructure. And I just want to say that from a consumer perspective, I think that approach makes a huge amount of sense. Otherwise, hospitals may have a free rider problem where some make investments, others don't, and they all benefit from improved population health. And if we want a consistent across the board, hospital by hospital investment in community care infrastructure, the kind of approach that was being discussed today, I think, makes enormous sense. So I just wanted to register my strong support.
Thank you. And Meg, can you talk? Or
yes, my comment goes way back to the discussion about the potential for an increase based on new drug costs. And there was some casual mention about, for example, oncology and hospice drugs. I wanted to make sure that we make a distinction of appropriateness where some of these new drugs may be utilized, such as the oncology drugs. If you're treating cancer very aggressively, they would be appropriate. If a patient is terminally ill and has been assigned to a hospice service, they may not be appropriate.
Thank you. So I guess I always wear the mask. It's 11:30. So I want to make sure we are respectful of the time, and we were quite ambitious with our topics. So we'll in term. I think maybe I don't know, Donna, if you want to.
Mention what you'll be providing more data, and we'll just continue the discussion on the update. Anything more specific you want to say about the meeting in April? If not, that's fine too. I'm just curious about the payment update. What do we expect to be focused on in the April meeting?
We have a list here. I think there's a document, an agenda here that goes through what we would expect to focus on in the next meeting, which would be the update factor, the uncompensated care policy, the shared savings adjustment, which we didn't really get into today, and a few other topics.
Okay, that's fine.
We might add one additional hour or hours to the agenda, given that we have more items for the next one. So we'll be in touch with you on the scheduling. Yes, that's the next.
So the next meeting is
April 15, Tax Day.
1 to 3.
At this moment, it's 1 to 3.
So get your tax return mailed in the morning, because we may see about moving that from 12 to 3 and trying to twist somebody's arm to get lunch here or something.
Yeah. Yeah, I doubt that we will
be successful.
Yeah, given what we did today.
So, are we officially done? We're officially at the witching hour here, and we didn't get into the next set of topics.
I got a free ride.
Yeah, absolutely. That would be helpful.
So should I talk to Jeff about the numbers that you have on that?
Yeah, and Jack has them too. He got them from the data set. I don't know if he got them. Right.
He's not able to look at the out-of-state Maryland. Is that not an
I mean, we can look at the Medicare data too. Yeah. I think. Okay. Perfect. Thank you.
Yeah, the plan was to cover that in the agenda item 3 to talk about it. Basically, maybe for the next meeting in general, the discussions we would like to have is the measurement of the potentially avoidable utilization, and then what the value-based purchasing amount should be in the update factor.
Right. So I think we were focused on potentially doing the shared savings adjustment and including PQIs in the calculation and possibly other PAUs. Right now, it's just based on readmissions, but possibly expanding that to include PQIs and other potential PAUs. So that was a discussion item to take back up. It was discussed in the performance measurement work group as well.
Right.
So it needs to be moved along on both fronts.
All right. So so it's a different measurement, but the amount incrementally the last couple of years, that's been a -0.2. Now it's a -0.5.
That's right.
You've got with the broader definition.
Well, I'm sorry we could have stayed longer, I guess. We have the advisory council meeting. I think they would need the room. But,